Good afternoon. Looks like it's noon, so we'll go ahead and get started. Thank you for joining us today. My name is Lisa Nagel from the Center for Collaboration Advancement in Pharmacy, also known as the CAP Center at the NDSU School of Pharmacy. We are pleased to welcome you to our series on chronic disease with today's focus on diabetes with Dr. Diana Isaacs. The webinar today is called Innovations in Diabetes Care. Before we get started, here are a few housekeeping items. Please use the Q&A function for questions during the webinar. We will answer all questions at the end, with time permitting. This webinar will also be recorded and located on the CAP Center website and YouTube page, and I will add these links to the chat as well. The CE information is for pharmacists and technicians and will be provided at the end of the presentation. After completion, I will also send an email follow-up with the links. Please feel free to share it with your colleagues or students. They can get on-demand CE for this webinar as well. Now I'd like to introduce you to our expert speaker. Diana Isaacs is an endocrinology clinical pharmacy specialist. She serves as the co-director of endocrine disorders of pregnancy and the director of education and training in diabetes technology at the Cleveland Clinic Endocrinology and Metabolism Institute. Dr. Isaacs earned her bachelor's degree in chemistry from the University of Illinois at Chicago, her Doctor of Pharmacy degree from Southern Illinois University, Edwardsville, and completed a pharmacy practice residency at the Philadelphia Veterans Affairs. Dr. Isaacs holds board certifications in pharmacotherapy, ambulatory care, and advanced diabetes management, and is a certified diabetes care and education specialist. Dr. Isaacs served on the American Diabetes Association Professional Practice Committee from 2020 to 2023, the committee that updates the ADA standards of care. She also served on the Association of Diabetes Care and Education Specialists Board of Directors from 2021 to 2024. She is currently on the leadership of the Diabetes Practice Group for the American Association of Clinical Endocrinology and is a planning member of their annual meeting and their Chair of Diabetes Technology Certificate. She co-hosts a popular podcast titled Diabetes Dialogue: Technology, Therapeutics, and Real-World Perspectives. She advocates access and choice to the latest technologies and therapeutics for all people with diabetes and speaks on diabetes-related topics both nationally and internationally. She was the ADCES Diabetes Care and Education Specialist of the Year in 2020 and inducted into the SIUE Alumni Hall of Fame in 2022 for her far-reaching contributions in diabetes care. We are so lucky to have Dr. Isaacs speak with us today. Thank you. Welcome, everyone. And Dr. Isaacs, go ahead and take it away.
Awesome. Well, thank you so much for that introduction and the invite to speak to you all during your lunch today. Fortunately, I'm on East Coast time, so I already got to eat my lunch, so I am loving the time difference. Anyway, I'm going to dive right in because there's so much I want to discuss. So the title is Innovations in Diabetes Care, 2025 ADA Standards and Pregnancy Updates. And so we are going to be focusing on new updates to the standards of care for 2025, and then with a specific focus on pregnancy technology and medications. So these are my disclosures. And then in terms of pharmacist learning objectives, so we're going to be describing key updates with the standards of care. We are going to be examining recent innovations in diabetes management, and that especially is going to include meds, CGM, and insulin delivery systems. And then I'll be discussing the latest guidelines and recommendations for managing diabetes in pregnancy, and then designing a treatment plan taking into account individualized factors to address acute and chronic complications. And we will be keeping this interactive. I've got several questions and case-based things throughout the talk. And then this also is approved for technicians as well. And the one difference is that last learning objective instead says support the pharmacist in designing a treatment plan that takes into account individualized factors to address acute and chronic complications. All right, so let's dive right in. Quick review on the standards of care, that these are updated every year based on the latest scientific diabetes literature. So a literature search is done each year and new evidence is added, and then recommendations are made based on that evidence. This is done by the Professional Practice Committee. And even though this is updated every year, there are also living updates that come out typically a couple times throughout the year as new evidence comes out. And this comes from ADA's general revenues. This is not an industry um, supported publication to really try to reduce any potential bias. Here's the full table of contents. So you could imagine we're not going to be able to discuss all of the updates, but I'm going to pick some key pearls throughout. And then I did just want to highlight the levels of evidence, with A being the strongest recommendation, and it goes down to E, which is expert consensus from the Professional Practice Committee. All right, so let's dive in. I am starting off with section 2, which is the diabetes and classification of diabetes, or diagnosis and classification. So I want to bring up type 1 diabetes screening. This is something that is becoming more and more important because we have many people that are walking around thinking they have type 2 diabetes and actually have type 1 diabetes. And in addition to that, we now have a treatment that can be used if someone is in what's called stage 2 type 1 diabetes that can actually delay the progression to stage 3. So the auto antibodies that the standards of care call out are these 4 listed here. So the auto antibodies to insulin, the GAD antibody, the islet antigen 2, as well as the zinc transporter 2. There is another one called ICA, that's a 5th auto antibody, but the reason that one is not specifically called out is because it's really harder to collect an accurate specimen and get an accurate result. So these are the key 4 you would test for. So it's recommended to actually be checking these in those that have a family history of type 1. So that typically would be like a first degree relative, so sibling or mother, father, or child, or otherwise might have some type of known elevated genetic risk. And then standardized islet autoantibody tests are recommended for classification in those that maybe have a picture where there's some question, do they really have type 2? Maybe they were diagnosed, they experienced ketoacidosis, or there's been a lot of weight loss, or just kind of not the clinical picture of type 2. And then they also call out that those that have what's called pre-symptomatic type 1 diabetes, that they actually monitor them every 6 months with an A1C, and also at least yearly with an oral glucose tolerance test to monitor the progression to stage 3. So in case you're not familiar with this, what do I mean? What are these different stages? Like, some of you might be thinking, I just thought there was type 1 diabetes and type 2. Now you're saying there's stages of type 1. So yes, there are. There are 3 stages of type 1 diabetes. And stage 1 is when you have 2 or more autoantibodies, but you don't have any abnormal glucose. Your glucose is totally normal. That is what I would consider to be a ticking time bomb, because anyone who is in stage 1 has basically a 100% chance, lifetime risk, of going on to stage 3, where they will have full type 1 diabetes, dysglycemia, and require insulin. Now, stage 2 is when someone also has those 2 autoantibodies, but they have some dysglycemia, not enough to maybe need insulin at this point. You can kind of think of this as like pre-diabetes with autoantibodies. So you would expect an impaired fasting glucose up to between 100 and 125, an oral glucose tolerance test that would give an abnormal result between 140 and 199, and then a slightly elevated A1C between 5.7 to 6.4. And the reason this is so important to classify is that we now have a therapy that can be used to help delay the progression to stage 3, and that is called teplizumab. Tzield is the brand name. This is FDA approved for ages 8 and over in stage 2 type 1 diabetes. And you can see this guideline recommends that this should be discussed with individuals that meet this criteria. And this is a level B recommendation. Just for your own knowledge, this is a 14-day infusion. Each day is about a 30-minute infusion plus pre-medications, but it is just a one-time dose, and it delays the progression in the the TN10 trial by about 2 times as much compared to if you did not take this medication at all. All right, next, let's jump now to chapter 4. I want to mention MASLD, metabolic dysfunction associated steatotic liver disease. So MASH and MASLD are getting a lot of attention because we see this huge overlap with obesity and liver disease and type 2 diabetes. And so now there is a very simple to use test called the FIB-4. And why I say this is simple is because this is basically based on labs that we're typically already checking. It's based on the ALT and AST, so these liver function enzymes, and then platelets, which we get from a complete blood count. So those are usually pretty standard labs. In our electronic health record, I use Epic, and it actually automatically calculates it. I have it as a dot phrase, that's part of my note, and so automatically I'm getting this result. And so we have this treatment algorithm that says if the FIB-4 is greater than 1.3, then you want to go ahead, and it means the person would have a higher risk of potentially future cirrhosis, and they should ideally get some imaging done. So a fibroscan is a common test that can be ordered. And then based on the results of that test, you might refer to a liver specialist or a liver clinic. If not, then you may just go ahead and treat the risk factors, which you'll see on the diagram on the next slide. If they don't have this, then they have a lower risk, and you'd want to go ahead and repeat this measure at least every 1 to 2 years and still optimizing those lifestyle and treatments of comorbidities. So what are those lifestyles and what are the treatments for it? So this was added. This is a really nice visual. At least I think so. And it's talking about, okay, well, you want to have these healthy lifestyle changes for everyone, right? Weight loss if indicated, cardiovascular risk reduction, offering metabolic surgery if necessary to help with weight loss. But then if someone has MASLD with F0 to F1, meaning there's no to minimal fibrosis, you would want to go ahead and use obesity pharmacotherapy. So preferably a GLP-1 receptor agonist or the dual GIP GLP-1, which is tirzepatide. For diabetes management, those also work great along with the TZD pioglitazone as well as SGLT2 inhibitors. Now, what if someone has MASLD that's F2, classified as F2 or F3, meaning they're at risk of MASH? Well, then again, that obesity pharmacotherapy, we're still going to want to use a GLP-1 receptor agonist or tirzepatide. For diabetes pharmacotherapy, specifically, we want to use a GLP-1 or the tirzepatide or pioglitazone, because those 3 classes of medication have really demonstrated improvement in people that have MASH or at risk for MASH. And then we can also consider a specific MASH pharmacotherapy, which we have a recently new drug called resmetirom. That is a more expensive medication, and it can be more challenging to get approved, but now that is listed in the guidelines. And then you can see that when someone has compensated cirrhosis, that is going to change the treatment. And if they have decompensated cirrhosis, then we're specifically going to be using insulin. And that brings me now to my first kind of audience response question. You can feel free to drop it in the chat to, participate if you want. So according to the 2025 ADA Standards of Care, which of the following medications is preferred if a patient has MASLD? And would it be A, sitagliptin, B, pioglitazone, C, metformin, or D, glipizide? And it looks like some of you thank you for those that are participating with the Q&A feature. And I'm seeing a bunch of people are putting B, and that is correct. So pioglitazone is a TZD. And thiazolidinedione, I can say it. I've had to practice a lot, but I can say it. And that would be the correct, because in addition to that, we could also pick like a GLP-1 or tirzepatide, but those are not choices on here. All right, very good. So next, I wanted to just share this. There's no way I can read all of this, but I love this diagram. This is in section 5, facilitating positive behaviors and well-being to improve health outcomes. And it really emphasizes all of these important lifestyle habits of breaking up prolonged sitting, trying not to be sitting for more than 30 minutes, which I realize I'm going to be sitting more than 30 minutes presenting to you, but I am kind of moving around, so it's okay. Hopefully you all will kind of get up, maybe do some jumping jacks throughout. We want to be sweating. Maybe you don't have to sweat during this talk, but we're aiming for this moderate to vigorous activity, at least 150 minutes per week. The strength training is also really important, especially as more people are on these incretin therapies that promote a lot of weight loss and can also lead to muscle loss. And then sleep. Sleep is so important, trying to get 6 to 8 hours of sleep every night. And so we want to, of course, be emphasizing these very important behaviors. And in this little table here, it shows you what you might expect in terms of effects on glucose, blood pressure, A1Cs, lipids, physical function, depression, and quality of life. And I always say physical activity, I am such a proponent of it. You can see on here, there are just really so many benefits. That sweating there, all the green arrows are going down, they're going in the right direction. And it so many benefits. All right. So now I'm already in section 6. Told you we're gonna go fast, right? So section 6 are the glycemic goals and hypoglycemia. And here, just a couple updates with a recommendation. So what I'm showing you on here is an ambulatory glucose profile report. This is not new. This has been in the standards for a few years, but they do have a sample listed here. And then the recommendation, 6.1, is to assess glycemic status by A1C or CGM metrics such as time in range, time above range, and time below range. And I just wanted to bring that to everyone's attention because that means we don't necessarily have to only use A1C. The guidelines advocate that we can use CGM data and we can be looking at that time and range to really guide treatment. Additionally, it goes on to say specifically that a fructosamine, which can be a substitute for an A1C, or CGM can be used for glycemic monitoring when an alternative to A1C is required. So thinking, some people they have severe anemia, kidney disease, or altercations in their red blood cell that make their A1C not accurate. And the guidelines say we can indeed use substitutes. You should use substitutes because the last thing you would want is someone's A1C, they have severe kidney disease and it's showing their A1C is like in the fives and you're like, great, we'll do nothing. But really their glucose is running in the 200 or 300s. We would definitely want to intervene and have a more accurate way to assess that. And then they also say use of CGM is beneficial and recommended for individuals at high risk for hypoglycemia. If you look closely, section 6 has actually been renamed glycemic goals and hypoglycemia. And there is a much greater emphasis on hypoglycemia now, and especially about those ready to use glucagons as well. This is a new diagram. This is not new material. The standards have always had this figure that showed how we might change the A1C goal based on different factors, like someone's social support, how long they've lived with diabetes, what medications they're taking. But this is a new visual where they show kind of different, the different places in life, like someone maybe younger, very good health function versus an older, more complex patient. So I do think the new visual is nice. My only feedback on this is I would have loved, in addition to the A1C goal, I would have loved that they put a time and range goal there as well. But maybe next time they'll add that. All right, now I am going to focus on specifically diabetes technology and what is new there in the guidelines. And we do indeed have several CGM devices now, but really there's 4 manufacturers of it. So we've got the Libre systems. You can see on here Libre 2 and Libre 3. By the way, those are being phased out, and Libre 2 Plus and 3 Plus are going to be the only ones you can get, I think, by September of this year. Very, very similar, just some minor differences, good differences really, that the Plus versions are the ones that can work with insulin pumps to automate insulin delivery. They are now 15 days instead of 14 days. And then the age is age 2 and up instead of 4 and up. And then the vitamin C interaction has been mitigated, meaning it takes a lot more vitamin C now to affect those results. Eversense in the middle is our only implantable CGM. So this is implanted under the skin and stays there for up to 1 year. The Guardian 4 is the sensor that works with the Medtronic 780G insulin pump. And then next to it is the Simplera. So the Simplera will be coming soon. It was FDA approved. However, it's just not available yet. It is in Europe and other countries. But this, what you'll notice, that big change with it is a fully disposable device. It looks more like a Libre and a Dexcom G7. There is no longer going to be a transmitter that you need to charge in between use and save. And then at the bottom, we have our two Dexcoms, Dexcom G6 and G7. Big differences are that the G6 does have a transmitter that you save for 3 months. The G7 is a fully disposable device. And then both of them are 10-day wear times, although G7 has submitted for 15 days. We'll see if that becomes 15 days in the near future. Here's just a table, and you guys will hopefully you'll have access to these slides and everything, so you can take a deeper dive later. But this is showing the pump integrations. This continues to expand. So we expect to continue seeing more integrations happening. Like, for example, Eversense right now doesn't work with any pumps, but it is cleared to use with pumps. So I would expect hopefully we'll see some integration in the future. You can see there are differences with warm-up times, just meaning how much time it takes before a person can see their glucose readings. Good thing is we've gotten away, very far away from calibrations where you need to do finger sticks for the device. You can see that most of them don't require calibrations. Even the Guardian 4, you only need to do it periodically to enter into automated mode. And even the implantable Eversense, now it's down to once a week. And they all have different data platforms to access the data. And just continuing on, this shows the FDA approved sites and ages. And what I especially want to point out, since I was asked to also cover pregnancy and pregnancy updates, is that the Dexcom G7, as well as the Libre 2 and Libre 3, as well as 2 Plus and 3 Plus, are all cleared for use in pregnancy. So that is a big deal. Those devices can be used. There is no contraindication. Also, one other thing I just want to point out, these drug interactions as pharmacists and pharmacy technicians, these are important. Vitamin C, if someone was taking really, really high doses, it could still affect the 2 Plus and 3 Plus. Hydroxyurea will affect the Dexcom and the Guardian 4. And acetaminophen, so Tylenol, actually affects the Guardian 4. And Tylenol can also affect Dexcom if it's in doses that are higher than the recommended dose. So beyond 4 grams per day could actually still falsely elevate those readings. And then newest, and these are also called out now in the guidelines, there is a category for over-the-counter sensors, or they call them biosensors, and that we have 2 of them available, the Dexcom Stelo and the Abbott Lingo. The Stelo is designed for people, both of them are designed for people over 18 that do not take insulin. And there are some differences between the CGMs. The big one is that there's not alerts for low glucose values because they are designed for people not taking insulin. So type 2 diabetes on, non-insulin medications, or someone with pre-diabetes, for example, or even just someone that doesn't have anything, but just kind of wants to see how their glucose levels are fluctuating. Here's the Abbott Lingo. There are certainly differences between the devices. Lingo has this really interesting point system. I've included the website, so anyone, you can be watching this right now and you could go on your phone or your computer and go ahead and order some sensors. They're about $89 per month for 2 of them, although you can get them a little cheaper or more depending if you buy one or you buy multiple sensors. And here's just a comparison. The Lingo is based off of it looks like a Libre 2, but it is real-time CGM. It lasts for 14 days. And then the Dexcom Stelo actually lasts for 15 days with a 12-hour grace period. And it looks just like the Dexcom G7. And so, yeah, give it a try. Can be a nice option for people that maybe don't have coverage for CGM. So, what do our guidelines, what do the ADA standards of care say about using CGM? Well, there have been some nice updates this year. So, for starters, the whole beginning of the chapter, it says diabetes devices should be offered to people with diabetes. So, we never want to just assume, oh, well, someone's does isn't smart enough or they're too old. Like, we don't want to make any assumptions. We want to make sure we're offering these technologies to people. It says level A recommendation, initiation of CGM should be offered to people with type 1 diabetes early in the disease, even at time of diagnosis. And thanks to our CGM manufacturers, there are often hospital programs where we have them in the hospital and we can offer one to someone right at discharge. It says recommend CGM for diabetes management to youth and adults with diabetes on any type of insulin therapy. And then consider using CGM in adults with type 2 diabetes treated with glucose lowering medications other than insulin to achieve individualized glycemic goals. And that's level B. And so you can see, like, even once a day insulin, even people not on insulin, guidelines are really encouraging that offer of CGM. And then 719 is in circumstances when consistent use of CGM is not feasible, consider periodic use of personal or professional CGM to adjust medications or lifestyle. And professional CGM is owned by the clinic. It is often lent out to the person 2 to 4 times per year, and there tends to be very good insurance coverage for that. So that can be an option as well. And of course, our guidelines don't say you should use this device or that device. They say it should be made based on an individual circumstances, preferences, and needs. So the next big piece of technology is automated insulin delivery systems, insulin pumps. And I've listed them all here. There's really four major insulin manufacturer, or sorry, insulin pump manufacturers with a fifth about to come to market. So that includes our Omnipod 5 by Insulet. We have the Tandem has both the T-Slim X2 as well as the Mobi. And then Medtronic has their 780G, and then Beta Bionics has their iLet. There are certainly differences that are beyond the scope of this presentation to discuss between the devices. For example, Omnipod 5 is a tubeless device. Mobi, everything is really controlled by the phone, even though that there is some form of tiny tubing. iLet has a very easy setup where you don't need to program settings. You just need to put the weight in. And 780G has a very aggressive algorithm that if someone forgets to bolus, it kicks in with these auto corrections. So there's nuances with the pumps, which makes the ability to choose for an individual really important. And then also on here, you'll notice that there is the Twist by Sequel. And this is the one that is going to be coming out very soon. It was FDA approved. We're just waiting for the product to become available. And this is going to use a Tide Pool Loop app, which is on people's mobile phones. And one of the nice things is now all of the pumps have mobile apps as well as the CGMs, and that makes data sharing so much easier. And then in the blue up there, I have CAM APS because this is one that was FDA approved and it is available in Europe and the UK. It is not clear when it will come to the US or be available in the US, but I'm going to be coming back to this when I talk a little bit more about pregnancy. So I wanted to make sure that I do mention that right now. So, what do our guidelines say about insulin pumps? Who should be using them? Who should not be using them? So, we have here automated insulin delivery systems should be the preferred insulin delivery method to improve glycemic outcomes and reduce hypoglycemia and disparities in youth and adults with type 1 diabetes, level A. I mean, you cannot get stronger than that. So, if you have any patient with type 1 diabetes, or you know someone with type 1 diabetes and they are not using an AID system, at the very least, we should be asking, has anybody talked to you about that? Have you been offered one? Do you know about them? And this is because the outcomes with them are generally so much better than when we just use injections. Now, that is on a population level, and certainly there can be individuals that just for a variety of reasons may prefer to use injections or may prefer not to wear a pump, but we should at least be offering it. And it goes on to say in other types of insulin deficient diabetes. So that includes people with type 2 diabetes that require insulin. It is a level E recommendation because there is not as much evidence, although I could see this becoming stronger next year because recently the Secure T2D study with the Omnipod 5 in type 2 diabetes was published, and that showed very nice outcomes. And so I could see that this would have a higher grade perhaps next year or the next update. And then it goes on to say, well, insulin pump therapy, preferably with CGM, should be offered for diabetes management to youth and adults with type 2 diabetes that can use the device safely. And that support and diabetes management advice to people with diabetes who choose to use an open source closed loop system. So, what is this last one saying? What is 729 saying? So there is a group of people who have been frustrated with the slow movement of the FDA, which could end up being even slower in the near future, but the slow movement, and they knew this technology existed. And so they're actually worlds ahead of where we are with FDA approved AID systems. And they have created very advanced systems. And what this is saying is that if people choose to use these systems, we as healthcare professionals should be supporting them in their choice. So I'm very impressed that this recommendation was added because in the past they just really shied away from these devices since they weren't FDA approved. But I think this is really speaking to the safety that has been collected from these devices and just offering patient choice. Okay. Well, what about medications? That's all great. That was technology. What about all the medication updates and the standards of care? Well, the algorithm looks different. So, fortunately, a lot of it is similar. You will notice that it's similar structure, and that on one side of it, you've got, okay, what's your goal? Does somebody have pre-existing kidney disease, heart failure, or cardiovascular disease, or they have a lot of high risk for cardiovascular disease? Well, then you're going to want to use a therapy that is going to show benefit for those conditions. And so this is very similar to what was in the algorithm the last couple of years. For those with cardiovascular disease or high risk, we're going to use a GLP-1 or SGLT2 inhibitor with proven benefit in this population. And if you need a second therapy, you'll just use the one that you haven't already used. So a lot of people end up on an SGLT2 inhibitor and a GLP-1 agonist. For heart failure, SGLT2 inhibitors are still the go-to agent, although there is a new recommendation now for people with heart failure with preserved ejection fraction and they have obesity. The recommendation is to use a GLP-1 with proven benefit in that population. And that is because semaglutide had a study that showed benefit for heart failure with preserved ejection fraction. So it didn't make it to the algorithm, I think, because it was studied in a population with obesity, but that is a strong recommendation that was added to the text. And then the other difference is with kidney disease. So in the past, it was always like, okay, kidney disease, use the maximum tolerated ACE and ARB, which is still there, and then SGLT2 inhibitor. But what you'll notice now is it says SGLT2 inhibitor or GLP-1, and both should be with proven benefit in that population. This really comes from the fact that semaglutide recently got an indication for people with type 2 diabetes and kidney disease from the FLOW trial. So those are the big updates there. On the right side, not really much has changed on this side. For those that don't have these other conditions, pretty much we have one of two paths we want to take. It's okay, are we focused on we really want weight management? Because we know that 90% of people with type 2 diabetes have overweight or obesity. Or is it that we are trying to really focus in on glucose goals, that someone maybe they're starting at a 9.5% A1C and we're trying to get below 7. And so we need agents that are going to be really potent for glucose lowering. So fortunately, there's a lot of overlap in both categories. You'll notice that, for example, semaglutide and tirzepatide are both going to be very high efficacy for weight loss and also very high efficacy for glucose lowering. On the achievement and maintenance of glycemic goals, this is where metformin is. It says metformin or other agent to achieve the necessary glucose lowering. And so even though metformin is so small now, it used to be this like big at the top, metformin first line and then everything else. It's still there. And the reality is it's still often first line for most people that don't have these other conditions. And even when they have the other conditions, often we're using them with metformin. But because it doesn't have all of those cardiovascular outcome data like SGLT2 inhibitors and GLP-1 agonists, it's just not as loud in the algorithm anymore. What is new and very important, and I couldn't get it all in one page, which is why this actually is supposed to be connected to that the diagram that you just saw on that other slide. But it goes on to say, well, if there's additional cardiovascular and kidney risk reduction, management of other metabolic comorbidities, or glycemic lowering is needed, then you want to ask, well, is there a mitigating risk of MASLD or MASH? And if there is, which often that's where you do your FIB-4 score, and often there is overlap with type 2 and obesity, then you want to use those agents that have the potential benefit. And that comes from that previous diagram I showed toward the beginning, that GLP-1 agonist, the GLP, GIP, tirzepatide, pioglitazone, or some type of combination. And if there's decompensated cirrhosis, use insulin. And I also like this part on the right is not new, but if A1C remains above goal or there's significant hypoglycemia, make sure you're referring to diabetes education. Consider use of technology and also address those social determinants of health. All right, so that brings me to my next interactive question. KT has kidney disease, obesity, hypertension, and type 2 diabetes. He currently takes metformin, 500 milligrams twice daily. Which of the following agents has the strongest evidence for improving kidney outcomes in people with type 2 diabetes? And I sort of referred to this, but I haven't completely gone over this yet. So let's see what you guys all think. You can drop your answer again in the chat or the Q&A if you're able to. I'm not even sure I can see the Q&A at this point. So I may just go ahead and give you the answer at this point. So dun, dun, dun. The correct answer is semaglutide. So that comes from the FLOW trial, which showed that there was a benefit using semaglutide in people with type 2 diabetes and CKD. Now, this is tricky. I would say it's a little tricky because we know SGLT2 inhibitors have benefit for kidney disease. But I listed ertugliflozin, and ertugliflozin actually is one of the SGLT2 inhibitors that has not shown benefit in kidney disease. So speaking of these indications, I'm not listing I have these tables on all the trials and everything, but like there's only so much I can squish into one presentation, right? So instead, I'm showing you the FDA approved indications for both GLP-1s and SGLT2 inhibitors. So on here, and this should be GLP-1 GIP because I put on tirzepatide, Mounjaro on here as well. All of them are approved as an adjunct to diet and exercise to improve glycemic control in adults with type 2 diabetes. Several have additional indications, like liraglutide also has the indication to reduce MACE, major adverse cardiovascular events, in people with established cardiovascular disease. Semaglutide has also that indication to reduce MACE. MACE usually refers to heart attacks, strokes, and cardiovascular death. And it also has that indication for adults with CKD to reduce the risk of kidney disease as well. And then exenatide extended release, as well as liraglutide and dulaglutide, all have indications for 10 and over. Interestingly, semaglutide, the obesity version of it, Wegovy, has an indication for 12 and over, but not the diabetes version of it. It's really how it was studied. And then you'll see dulaglutide also has the risk of MACE, and it specifically says for established cardiovascular disease or multiple risk factors because of the way it was studied. It was studied in people that had cardiovascular disease, which is how most of them are studied, but also it included a number of people that had high risk factors but did not have established cardiovascular disease. All right, what about the SGLT2 inhibitors? So there are 5 that are approved for diabetes. There is also a SGLT1/2 inhibitor, sotagliflozin, but that has a heart failure indication. It's not specifically for diabetes, so I didn't include it here. So ertugliflozin and bexigliflozin have the indication for adjunct to diet and exercise to improve glycemic control, but nothing beyond that. DAPA, EMPA, and CANA, they all have these additional indications. They actually all have heart failure indications as well as kidney disease indication and MACE. Specifically, empagliflozin and canagliflozin are approved for heart failure and kidney disease in people with and without diabetes. So that is unique to those 2 medications. And then all 3 of those medications also have indications for 10 and over because there are a lot more kids now being diagnosed with type 2 diabetes. And I did want to call out, this is not a new recommendation, but I still think it's very important that once an SGLT2 inhibitor is initiated, it's reasonable to continue even if the eGFR falls below 20, and continuing it up until dialysis would need to be initiated. So we are much more liberal now with our use of SGLT2 inhibitors for people with kidney disease. One thing to keep in mind is that once the GFR goes below 45, the amount of glucose lowering that you're going to get from the agent is quite minimal. So you need decent kidney function for these drugs to work to clear glucose out. Now what I wanted to point out here, this diagram is also in section 9 on the pharmacologic approaches to glycemic treatment. And it talks about, well, when do you initiate insulin? How do you go about doing it? This is not new, but what I wanted to emphasize, because I still think this is such an important point, is that the first injectable therapy should ideally be an incretin, a GLP-1 agonist, or tirzepatide. That should really be tried before starting insulin, assuming someone doesn't have contraindications to it. And actually, once someone has started basal insulin, we would want to add it before we escalate to mealtime insulin. So I do think that's a really important point. I feel like a big part of my job is I get people that are on insulin already and have not been put on these therapies before. And so we're going ahead and we're starting them, and then we're actually get to deprescribe the insulin. And CGM is a great tool to allow us to help do that to minimize hypoglycemia. Well, that brings me now to the elephant in the room. What about these compounded GLP-1s? And there was recently a position statement from the ADA, and then some language was also added into the standards of care. And the ADA is not in favor of compounded GLP-1s. They specifically say that use of compounded products that are not approved by the FDA is not recommended due to uncertainty about their content and resulting concerns about safety, quality, and effectiveness. And that, well, what do you do if there's a shortage or you don't have the dose that you need? It says if a glucose lowering medication is unavailable, it's recommended to switch to a different one that has similar efficacy. So example, tirzepatide's out, switch to semaglutide. And then it says upon resolution, go ahead, reassess the appropriateness of switching back or continuing with what you have. The shortages for tirzepatide and semaglutide have been declared resolved by the FDA. Of course, we know that it sometimes in the real world can still be challenging getting the medication. But all that to say is that there's probably going to be more crackdowns on compounded pharmacies. And so there is going to be a need for patients to probably switch to formulations that are FDA approved. Both Novo and Lilly have these direct programs where they have offered a lower price version of their drugs. However, they're still quite expensive. I mean, ranging the cheapest is now $350 for a 2.5 milligram tirzepatide, 500 milligram for semaglutide Wegovy doses. So, I mean, it's improved for sure, but it's still going to be, I suspect, out of reach for a lot of people if they don't have insurance coverage. All right, moving right along. This is like pow, pow. All right, diabetes and pregnancy, because that is in the title. And I said I would talk about pregnancy updates, and that is indeed what I'm going to do. So there is some language. Was added actually a couple years ago, but I think it's really important to emphasize. I work very closely with this population. We are seeing more and more people with undiagnosed prediabetes and type 2 diabetes. And for that reason, really there's a big push to screen people in the first trimester instead of waiting until that typical GDM screening where we would do that between 24 and 28 weeks. So guidelines say before 15 weeks of gestation, test individuals that have risk factors, but consider testing all individuals for undiagnosed diabetes. And at this point, you would use standard diagnostic criteria. So that would be like fasting glucose, A1C. This is not the point where you need to do like a 1 or 2 hour glucose tolerance test, according to the criteria that we normally test GDM, although I do find a lot of people are using that criteria. And then before 15 weeks, screen for abnormal glucose metabolism to identify those who are at higher risk of adverse pregnancy and neonatal outcomes or who may be more likely to need insulin. And they suggest that using a threshold of fasting between 110 and 125 and A1C between 5.9 and 6.4. And that would really be a threshold for closer monitoring to start checking glucose levels or using CGM throughout the pregnancy. For checking GDM, this hasn't changed. If it was a negative screen at that first visit, then you'd go ahead between 24 and 28 weeks, do either the 1 or the 2 step. In the US, a lot of times it is the 2 step where we give someone 50 grams of basically a very sugary drink to have, but they don't need to fast. And if that is over, for example, it's over 135, then they'd go ahead and come back and do this 100-gram oral glucose tolerance test following these thresholds here for fasting 1 hour, 2 hour, and 3 hour. And if 2 or more of those are elevated, then they get the diagnosis of GDM. What are the goals in pregnancy? Well, because there's increased red blood cell turnover, we expect A1C to be slightly lower. And also because we really want the best outcomes for the baby, we have tighter goals. So we're aiming for less than 6% in that second and third trimester if it can be safely achieved. And they call out that CGM can help to achieve glycemic goals and A1C goal in type 1 diabetes in pregnancy and may be beneficial for other types of diabetes in pregnancy. That is a level E, just because there is less evidence for GDM and pre-existing type 2. But I can tell you this is progressive compared to where we've been. The guidelines for pregnancy used to be very much like BGM all the way. Don't use CGM. If you use CGM, you must confirm every reading with BGM. And you can see they're a little looser now and a little more favorable for CGM. The thresholds for BGM have not changed. Fasting under 95, 1 hour post meals should be under 140, and 2 hour post meals should be under 120. And there is a lower threshold if someone's on insulin just because we're trying to avoid hypoglycemia. And there are certainly some additional recommendations about CGM. Recommend CGM to pregnant individuals with type 1 diabetes. I am so happy to see that. And that it can help to achieve glycemic goals in type 1 and might be beneficial for other types in pregnancy. Oh, I do want to call out this fourth one. Commonly used estimated A1C and glucose management indicator calculations should not be used in pregnancy as estimates of A1C. So GMI is a CGM derived basically number that estimates A1C. However, as you get closer to normal glycemia, it tends to not be as accurate. And so for that reason, they're really saying don't rely on GMI to estimate A1C. You should really be better to look at the time in range and looking at average glucose. And I feel like that's a good thing to call out. All right. Well, I haven't mentioned this yet, but let's see if you know it. What is the target range using CGM in pregnancy? So, for those that may be less aware, outside of pregnancy, the target range is 70 to 180, but we have a tighter range in pregnancy. And so the question is, well, what is that tighter range? And I will show you. It is 63 to 140. So we indeed have a tighter range that we are looking for. And within that range, we are aiming for at least 70% in that range for those that have type 1 diabetes in pregnancy. There has not been as much evidence in gestational and type 2 diabetes. So the international consensus on time and range has this basically blank graph where it looks like the green bar is longer than the type 1, but it doesn't have a number. So what are we supposed to do with that? Well, fortunately, we have a lot of expert consensus, and I was fortunate to be involved with this group writing this paper. There's going to be another paper coming out soon with more details. But this is guidelines, and well, what if someone has gestational diabetes? The recommendations are for 90% or more in target range, while aiming for less than 4% of the time below that range and less than 5% of the time over 140. And so, especially if someone is managed with lifestyle and diet and not with insulin, then often we can get a lot more aggressive with these and really try to have as much time in range as possible. And in this kind of this consensus guideline, we said recommend CGM to all who are willing and able to safely use this technology. I didn't know if I really had time to include this, but I couldn't not include this because this is such cool data. This is from what's called the GLAM study, and they basically compared CGM data to people that developed gestational diabetes compared to those that didn't develop it. And they followed them really throughout almost their whole pregnancy. And the fascinating things are that there was actually differences much earlier on, like even already at 13 to 14 weeks. The group in the red has gestational diabetes, and then the group in the blue did not develop it. Look, there's a big difference in that average glucose and the time spent over 120. And so, and then by the time you get to 27 to 28 weeks, yes, that difference is even more. But that difference was there like very early on. And so, I mean, this is still early data that we need to figure out how would intervening affect outcomes. But this is kind of mind blowing, the fact that we don't test for gestational diabetes until weeks 24 to 28. But clearly, there is a difference early on. And maybe instead of having a target range of 63 to 140, maybe we really need to be looking at the time spent over 120 because there's clearly differences there. So it's just fascinating, and there's ongoing research in this area. Well, what do the guidelines say about pump use in pregnancy? This is also very, very interesting. So, first of all, insulin is the preferred treatment for anyone that needs medication in pregnancy. Yes, in the past, we were more inclined to use drugs like metformin and glyburide. Those have really fallen out of favor. They do cross through the placenta. At least half of people that are use those drugs end up needing insulin anyway. And so, for those reasons, really, insulin now has become our preferred agent. And when someone needs mealtime insulin, then we know a pump can certainly make it a lot easier to deliver the insulin. And so there's now a guideline that says AID systems with pregnancy specific glucose targets are recommended for pregnant individuals with type 1 diabetes. And then there is a third one that says, well, AID systems without pregnancy specific glucose targets may be considered for select pregnant individuals when using with assistive techniques. All right, so with that being said, which of the following automated insulin delivery algorithms is actually FDA approved for use in pregnancy? And you may have no idea, and that's okay, because I'm going to tell you there's only one. It is CAM-APS. And if you were paying attention earlier, you will recall that CAM-APS isn't even available. So we have one FDA-approved algorithm. It is called out that we should use FDA-approved algorithms, but we can't actually get it yet. So that creates a conundrum. Now, why is it FDA approved? There was this randomized controlled trial that was published in the New England Journal of Medicine when compared to using standard care, which was either multiple daily injections or an insulin pump without automation. The group that used the CAM APS achieved 68% time in range compared to standard therapy, which was 55%. I also just want to call out that 68%, the goal is 70%, but on average, they achieved 68%. This just shows you how hard it is when you have type 1 diabetes to achieve the recommended goals. It is very, very challenging. So even though, yes, we have this 70% time in range goal that we would love for all of our patients to attain to have the best possible outcomes, in reality, it is very hard to do, even in a clinical trial situation. So just keep that in mind. So here, May of 2024, CAM APS was approved. This is available in the UK and Europe. And we certainly hope this will become available because of its strong evidence in pregnancy. So why is it then that this is the only approved algorithm in pregnancy? We have a ton of great insulin pumps in the US. The reason why they're not approved in pregnancy is because the lowest glucose target, I have highlighted them in yellow, I've listed them all here. CAM APS can go down to 80. Well, that's awesome. When you're trying to really maximize your time between 63 and 140, you want a target that is going to be lower. When you compare that to the others, Omnipod 5 is 110. Control IQ, the lowest range you can do is 112.5 to 120 in the sleep mode. 780G is the next lowest at 100, and then iLet is 110. So all of those are much higher. Now, why are they higher? I'm sure it's not that they wouldn't be willing to try lower, but the issue is weighing hypoglycemia risk with the lower target. And so it can be very challenging to lower the target without causing hypoglycemia. And so that's why we have these higher targets with the other systems. Now, Tidepool I've listed up there, that has a target down to 87. That is the algorithm that's going to work with the twist pump. And so I think that's really exciting. We will get to see how that works because I could see that working well in pregnancy, but we don't have it available yet. So we cannot say for sure, and it doesn't have the FDA approval there. All right, some additional just things about pregnancy. I've really highlighted these, so I'm not gonna go through these again, but I do want to share, kind of conclude on a patient case. So we have Abby, who is a 34-year-old female newly diagnosed with type 2 diabetes. Her A1C is 7.6, her fasting glucose is 145, her BMI is 37. And the question is, well, what drug should we start? And we have the choices metformin, semaglutide, sitagliptin, which is a DPP-4 inhibitor, and empagliflozin, which is an SGLT2 inhibitor. And so here we come to our guidelines, and she doesn't have established cardiovascular disease, but she does have obesity. And so here we could pick a drug that has high efficacy for weight loss. So certainly we might want to go with semaglutide. But we also see when it comes to glycemic lowering, we could start with metformin. I think in the real world, we're going to start with metformin because most insurance plans are going to say you need to show you tried metformin before you can even get semaglutide. So that's probably what we're going to do in the real world. Although if insurance will approve either, we could go straight to semaglutide. And so let's go ahead and say that's what she did. We started her on semaglutide. So now it's a year later, and she is up to 2 milligrams weekly. Her BMI is 33, so it came down a little bit. And look, her A1C is 5.7%. Fasting glucose is 104, but she found out she's 5 weeks pregnant. What should we do with her medication? So we could stop and monitor. We could continue the semaglutide and say, it's working well, let's keep it up. Or we could stop and switch to insulin, or we could stop and switch to metformin. So I'll tell you, what I would do in this situation, we have to stop the semaglutide. It is not an approved drug in pregnancy. We must stop it. Because her fasting glucose is 104, I recognize her A1C is 5.7, but remember, it's also it could be a little bit falsely low in pregnancy. And because her fasting is above the target of 95, we need to do something. Insulin's going to be our first line. And so most likely we would go ahead and we would switch to insulin. And then my last question for you, is she a candidate for CGM? I hope you all are saying yes, 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 yes. Of course, she's taking insulin. She's pregnant. We've got FDA cleared devices, Dexcom G7, Libre 2, Libre 3. Yes, let's use CGM. And so, just kind of wrapping it up, summarizing, we went through lots of recent updates. It talks about so many things. When to screen for type 1. Remember, we talked about that in the beginning. We talked about teplizumab. Standards of care advocate for more use of CGM and insulin pumps and AID for people with diabetes. Screen early for hyperglycemia in pregnancy. Insulin's our number one drug, and we have CGM. And I believe I have taken you up pretty much the full hour. Here is my contact information. I also have a podcast called Diabetes Dialogue that I do with Natalie Bellini, an amazing nurse practitioner. You can find that wherever you find your podcasts. And I am happy to answer questions if there's time. Otherwise, I'm going to go ahead and turn it back over.
Dr. Isaacs, wow, thank you. That was really, really well done. I appreciate your enthusiasm for the topic. There was a lot of information you shared and how all of the updates and how to keep our pregnant patients safe. So thank you very much. There are no questions right now in the Q&A. If anybody wants to enter a question in the chat, we probably have time for maybe one or two. If you want to come off mute and ask the question, that works as well. I will go ahead and pull up the screen share for the CE information. You're probably seeing everything. Okay, here's our CE information. And there's pharmacist code and a technician code. If you do not have a current account with CE Impact, it is free and it's just learn.ceimpact.com. I have that in the chat as well. Did you have any questions at all?
It looks like there's one in the chat. It says, off-label question, have you seen any data or know of ongoing studies using GLP-1s in type 1 diabetes? I can tell you I have a lot of patients with type 1 using these therapies. And sometimes it's not even off-label because, for example, if they're using it for obesity, I mean, technically it's being used for their obesity, right? And not for their diabetes. We are seeing great results. There is some data from Viral Shaw's group, mostly retrospective analyses, where they have shown that tirzepatide, semaglutide has led to weight loss and glucose lowering and has overall been shown to be pretty safe. I believe there's randomized control trials underway to really be able to support that evidence. And then I see one other question. When would you recommend checking C-peptide and fasting glucose or non-fasting? I've seen it recommended both and curious about what you do. So the most important thing, I think, it depends how you're using it and when you're checking it. But when I'm trying to confirm, for example, does someone have type 1 or type 2 diabetes, and I'm really trying to figure out, are they producing insulin? I don't ask them to fast because if their glucose is low, then you would expect their C-peptide could be low in that situation and it won't be as informative. So I don't have them fast, but it is very important to have that glucose level because if the glucose was low and their C-peptide's low, then they may actually have good insulin production. So I get them both together, and I think that really kind of informs their insulin production. Dosing recommendations for insulin reduction when starting a GLP. So it is going to be very individualized based on what their current glucose levels are and what their existing A1C is. There is a paper I was part of. It's called the Transition T2D study, where we took people on multiple daily injections. They had A1Cs, though, that were under 7.5. But when they were on mealtime insulin, we actually just stopped their mealtime insulin and we just gave them a correction factor to use. And that was kind of how we began that insulin adjustment. When somebody coming from a higher A1C, the way you approach it may be different. Sometimes I don't decrease it at all, and I just start with the lowest dose and monitor them. I love to use CGM for that reason. I would say on average, a lot of people I am decreasing by 10 to 20% when starting the GLP-1, but it's going to really depend on the situation. And I think I got the questions.
You got a ball.
I got
Awesome.
them.
Well, thank you so much. We really appreciate your expertise and take care. Everybody, thank you for joining us and we'll be in contact with emails afterwards.
Great. Thanks so much, everyone.
Have a great day. Bye.